we will be elaborating the competency 7.7, which states renal function tests with physiological significances, clinical implications of renal clearance, importance of renal clearance. Next competency is role of artificial kidneys, dialysis, and indications of renal transplantation, renal transplants. So these are few questions important from these competencies. Particularly, the clearance tests are very important. It may be creatinine, it may be inulin clearance test, or pH clearance test. Okay. Renal function tests are a group of tests that are used to study the abnormalities in renal function. We know kidney performs various important functions like excretion of waste products, maintenance of fluid balance, maintenance of electrolyte balance, maintenance of pH, acid-base balance. It also performs some other important functions like metabolic functions. We know nearly 30% of gluconeogenesis take place in kidney. Moreover, kidney acts as hormone gland. It synthesizes some hormones like renin, from which angiotensin 2 is formed through some activation processes. And this, we have seen how important this angiotensin 2 is. Moreover, it produces active vitamin D. Okay, so in this way, kidneys are very important to us. And any abnormality in these functions are identified, monitored, evaluated by kidney function tests. So, these tests are very important. These tests involve analysis of urine, analysis of blood, and the results of urine and results of blood can give another important functional aspect, not functional, I mean detection purpose, evaluation purpose, that is renal clearance tests. Okay, so we'll study first, we'll go through first the urine analysis. Okay, so renal function tests, what is the purpose, use of these tests? Why will we performing these tests? We will be performing these tests for this screening of renal diseases. Suppose we have to know, are there any students suffering from renal disease? So what will we do? We'll screen all of you. Okay, so for this screening purpose, to study the prevalence rates among the students, among the different communities. We apply this test. So this is one purpose, one importance is it can be used as for screening purpose, screening. And next is identifying the presence of diseases, renal diseases, identifying the presence or detecting the diseases, what kind of renal disease it is. Next, monitor the response of kidneys to treatment, whether it is improving or deteriorating. So that purpose, for this purpose, we also retest to see whether improvement or deterioration is going on. Other than this, another importance is determining the progression of renal disease. Okay, whether it is in which direction the disease process going on, whether it is improving or it is deteriorating. So, when a doctor, when you will be suspecting that a patient might have renal diseases, so what you will do? You will notice some sign symptoms that are reflected in renal diseases. So there are various sign symptoms. So you have to be concerned about these sign symptoms. Okay, what are these sign symptoms? Very important. When a patient gives these sign symptoms, so you have to think the patient might have renal diseases. Okay, in that case, what you will be doing? To confirm these sign symptoms, you are suspecting some disease. So what you will be doing? You will be advising some tests, renal function tests. Okay, so depending on some indications, you will advise the tests. Now, what are these indications that prompt one doctor to advise for tests? So these are the sign symptoms that are reflected in renal diseases. What are these? This is blood in urine. So blood is coming through urine. And foamy urine means a lot of proteins are going. Normally protein doesn't go. It's not present in urine, very small in amount. But when it becomes foamy, that indicates that through urine, protein is coming. And the turbid, it happens some of the urine may become turbid. And turbid urine, so these are the signs. And lethargy and weakness. Okay? And there is muscle cramping. There is dry and itchy skin. Okay? Because of high creatinine, high urea, these nitrogenous end products, they produce these sign symptoms. Okay? Increased urge to urinate. Okay? Especially at night. Usually we don't go to toilet because for at night. But when the patient says, I have to go twice, thrice. So that you may suspect there may be some renal disease. And there may be polyuria, oliguria, anuria, pyuria. What are these? Anuria means, anybody? What is anuria? No urination. The patient is not passing urine in last 24 hours, passing, but it is less than 100 ml. In 24 hours, it is how much? Less than 100 ml, and this condition is called as anuria. Below 100 ml. In some book or in some author, they says it is 50 ml. Okay. Next, there may be oliguria. Oliguria, less than normal urine the person is passing throughout the day. How much? 400 ml. Okay. 400 ml of urine, that is, he is having oliguria. And there may be polyuria. What is polyuria? there is more than 2 liters of urine the person is passing. Okay, that is ADS hormone is not working. That's why a lot of fluid is going through urine. So this is called polyuria. So normally we used to pass urine how much? 800 to 2 liters. 800 to 2 liters. Minimum for normalcy, minimum there should be 500 ml of urine formation. Because our body, they can concentrate the solutes, which are excretory solutes or waste solutes, minimum they require 500 ml. Okay, to excrete or to accommodate all these excretory products. Okay, so there may be poor appetite. There may be discomfort during urination. Okay, and there is puffy face, particularly around the or below the eyes, or there is pitting edema. Pitting edema. So these are indications that somebody may be suffering from renal diseases. So immediately you will advise what? This kidney function test, renal function test. Okay. So let us see urine analysis. So what analysis? What we will see in the urine? First we will see whether 24 hours urine that the patient is passing, is it adequate? Or are there any, is it below 100 ml? Or is it below 400 ml? Or is it normal within 800 to 2000 ml? Or it is more than 2000 ml? So we have to see that, the amount. Okay, so anuria, oliguria, polyuria, and there may be pyuria. What is pyuria? Pyuria is the urine having bad smell, and why? There are pyuria means there are pus cells. There are pus. What are these? Dead RBCs. Dead RBCs. Dead blood cells. Okay. So it reflects that body is infected. The kidney is or urinary tract is infected. Okay, so that's why the pyuria is seen. Okay, so then the polyuria, the condition polyuria can be seen in glucosuria. You can advise the patient is not giving any symptoms. Even then, a patient came to you, he came for some other purpose, and you noted he gave a history of diabetes mellitus. Okay, so in that we know diabetic mellitus can affect kidney. It can affect one thing. Usually what we do, take blood test and we say what is the creatinine level. But you know creatinine level comes beyond normal when 50% of your kidney gone. Then only creatinine level rises. So before that, actually deterioration of kidney function has started. So it has to be evaluated earlier, very fast. Okay. So for that purpose, there are different tests. Okay. So this is the physical examination of the urine. Next, let us come to the color of urine. So color of urine normally is what? It is amber yellow or light yellow. Okay, and it may become dark brown when if there is hematuria during blood cells in urine. So it may give you this color, and the cause is hematuria. Why hematuria happens? Because it is coming from the glomerulus. That means glomerular filtration membrane is affected. How it is affected? By infection. And this infection is called glomerulonephritis. This is because of infection of this is called glomerulonephritis. So in that case, what happens? The membrane, filtration membrane is disrupted, blood cells can come out, proteins can come out. Normally, it doesn't allow this. So when these are coming, so this is suspected, the patient is, there may be, since it is bacterial infection, there you may get some other, when urine is given for cultures, the bacteria will be there. So when it is given for culture, there will be development of bacteria. And resistance, what are the drugs, what are the antibiotics that can be applied for that purpose? What you do? CST, culture sensitivity tests. Okay, so pH, and that is when the urine is dark yellow, that means the patient is suffering from jaundice. Okay, and pyuria, pale, turbid urine. In case of pyuria, maybe because of infection. So in presence of infection, urine may be pyuria, pale, or turbid urine. There may be sin. And pH of urine, normally it is 4.5 to 8, but it can increase, decrease, particularly in different metabolic disorder, particularly metabolic acidosis or respiratory acidosis, metabolic alkalosis or metabolic acidosis conditions may change normal pH of the urine. So when the pH of the urine is changed beyond normal, that you can suspect that if it is, you can suspect there is alkalosis or there is acidosis. Okay, specific gravity in case of diabetes mellitus, specific gravity is increased. In case of diabetes insipidus, where more urine is passed, in that case, specific gravity become less. Okay, osmolarity is also decreased in diabetes insipidus, or when there is bacterial infection. So in that case, urine will give very odd smell. Okay, and then the microscopic examinations. So the urine will be centrifuged. The urine after centrifuged, and the residues will be tested under microscope, and you will look for whether there is RBC. If you find RBC, there is infection in the glomerulus. Okay, so it may indicate glomerular nephritis is there. If you can see whether, if you find there are RBC, that means it in the infection may be in cervix, it may be in vagina, it may be in renal tubule, it may be in urinary bladder, it may be in kidney. So from that areas, from these infections, the WBC may come. Okay, but other than this, epithelial cells. Usually normally epithelial cell, the renal tubule. So there are epithelial cells, inner epithelial cells. So these epithelial cells, they are not permanent. So we have seen in apoptosis. So these epithelials are constantly replaced. Okay, so these cells, apoptosis cells, where they will go? They will come in the urine. Normally they may be present. In one hyper area, you may get 2 or 3 epithelial cells, but when it is more, it indicates the epithelial cells are destroying. That is, epithelial cells are undergoing necrosis. Okay, so epithelial casts. The casts are made of some proteins. These proteins actually produce these casts, and these casts are maybe granular type, maybe tubular type. Maybe where the cast? Granular, there may be cellular type, some RBC joined together form casts. So these are cellular type, and there are granular types. They particularly, these granules, which one? Are seen particularly when there is proteinuria. When more proteinuria, more granules, more casts you will find. Crystals, different kinds of crystals are seen in, say, sodium oxalate, ammonium oxalate, these type of crystals are normally present when there is kidney stone. So the amount of oxalate will be increased. So more oxalate suspects that the kidney may have stone. Okay. So beside this, cysteine, tyrosine are also the crystals of cysteine, tyrosine may be seen in the urine, and these are actually liver disease. In liver disease, these are formed. And bacteria. So when you find the bacteria in the urine, so you can suspect, so there is infection in the urinary tract, in the upper urinary tract or in the lower urinary tract. So immediately what you have to do, you have to give the urine for CST. Now the analysis of chemical characteristics. Chemical characteristics means whether there is any glucose present in glucose. So when in urine glucose is present, if the patient is suffering from diabetes, or the glomerular epithelial membrane or the tubules that reabsorb the glucose after filtration, they are damaged. What means tubular necrosis. So in case not only in diabetes but in nuclear tubular necrosis, there may be urine may contain glucose. And the protein, normally amount of protein is very less. Only 30 milligram in 24 hours urine. Okay, so it should not go beyond 300 milligram per day. If it goes beyond 30 milligram per day, we call it it is the macroalbuminuria. Means more and more proteins are coming out through the urine. And if it is below 300, more than 30, then it is a microalbuminuria. There is no microalbumin. Means albumin is going very less in amount. Okay, all albumin are same. No macro, no micro. Only the quantity, amount. Only the amount differs. Okay, so albumin, in particular in nephrosis, in AKI. What is AKI? Acute kidney injury. It happens because of sepsis. A patient admitted in ICU for prolonged period, he may suddenly develop AKI because of sepsis. Okay, or it may be developed because of some drugs. Okay, so these are in this development, this renal disease, it happens only 15 in days. It develops, but in other kidney disease, it takes long time. But AKI happens very fast. Okay, and it is some, as I said, some drugs, some agents, some sepsis, they may cause AKI. In such case, lot of urine comes out. Okay, so when you suspect this, lot of urine, there is nephrosis. There may be AKI. Okay, then there may be blood in urine. You did it by microscopically. Here you find by test. What are the tests? What are the tests for blood? You have studied, no? Urine analysis? No? In biochemistry? How come? Okay, so there are tests for bile salts, bile pigments. Presence of bile salts, bile pigments, they indicate jaundice. Okay, so by this you can say there is jaundice. Ketone bodies, when ketone bodies is seen, in diabetes ketone bodies is seen. In fasting, starvation, ketone bodies are formed. In severe exercise, it is formed. Okay, in pregnancy, it may be formed. Okay, so ketone bodies indicate these are the condition. Okay, nitrite. These nitrite are liberated, are formed when there is infection, bacterial infection. Dipsticks method. One method is there, very simple. It's like litmus paper. You insert it into the urine, and there are a lot of marking or strips. The one will indicate if there is protein, high protein, this color will be changed. how much, what is the color, you match it. So in the protein, whether there is lot of protein, whether there is bilirubin, whether there is ketones, whether there is glucose, so only one stick can determine it. Presence of these things can be determined using these dipsticks. Okay. Now examination of blood. In examination of blood, what do we do? These are the tests we do. We call it blood for kidney function test, KFT. Blood for KFT. What are the things you will these are done in this KFT? Blood urea, serum, these are all the nitrogenous end products, and these are the electrolytes. And these electrolytes are changed if the kidney's power of electrolyte balance is disturbed. Then their values will also be disturbed. So from these values, we know when it exceeds 145, hypernatremia, it can produce in the body a lot of changes. When it is hyponatremia, we have discussed in our earlier class, say what hypernatremia, hyponatremia can do. What are the signs, symptoms would do? Similarly, hyperkalemia, also serious, it may cause serious impacts in the body, particularly on our heart. Our heart may be collapsed because if it becomes high, very high or very low. So, hypernatremia or hyponatremia is a serious condition. Similarly, when pH is changed in the blood, then the bicarbonate and chloride ion, their concentration will also be changed. Okay, and the arterial POCO2, arterial PO2, these are tested to respiratory, whether there is respiratory alkalosis or respiratory acidosis. To determine if we find the disbalance, then we will suspect there is respiratory alkalosis or respiratory acidosis. Okay, we are now coming into the most important thing, that is what? To assess the renal function. So here we will assess the renal function particularly by two important functions we will give. One is glomerular filtration rate. Another is presence of protein in the urine. How much protein is going? Okay, and what is the glomerular filtration rate? GFR. These are the most important thing. So before we start explaining the GFR and how it is determined, or what are the different GFR cannot be measured directly. GFR is measured indirectly. How? Through clearance test. So we have to understand what is clearance. What is renal clearance? Okay. So through the kidney, blood is coming, means plasma is going through the glomerular capillaries. So capillaries are actually filtered. So when this plasma will be going, this plasma is having some unwanted material, so they will be filtered. Okay, so this filtration of substances like urea, like inulin, like creatinine, like PAH, so we study their clearance. Means how much plasma is cleared of these substances in a particular time, in 1 minute. That is the clearance value. How much of plasma is separated from these substances in 1 minute. That is the clearance value. Okay, now this clearance value has got immense importance. So how this as I said, clearance values cannot be measured directly. So we depend on some other values, some substances. What are these substances? 4 important substances are there by which we can measure the GFR or clearance of different substances. What are these? These are creatinine clearance, inulin clearance, PAH clearance, cysteine clearance. So these are the clearance. We are coming one by one. But not all these clearances reflect actual GFR. So if we want actual GFR, what is the authenticate value of GFR? We will rely on inulin clearance test. Because this inulin, this is one thing, one problem with inulin is, what is inulin? It is a carbohydrate. Okay. Carbohydrates which are made up of only glucose molecules. What do you call them? Glucan. And those who are made up of only fructose, they are called fructan. So, inulin is one fructan. One interesting thing is, if you inject inulin in your body, it is neither, and it cannot enter within the cell, it remains within the blood vessel. When it passes through the kidney, glomerular nephron or glomerulus, the glomerular nephron completely filters it. So it is filtered. Okay, while it is filtered, it is the glomerular filtrate is going through the renal tubule. This is neither reabsorbed nor from the blood it is secreted. So that's the thing, ideal thing for the clearance, determination of clear. But only problem is, it is exogenous. To measure the clearance, inulin clearance, you have to infuse, you have to inject the thing into inulin into your body. So that is another problem. So what can be done? Okay, another substance can be used to measure the GFR. What is this? This is creatinine. This creatinine is endogenous. This is not exogenous. Our body is producing, our muscles are producing it. And they are filtered. And one problem is, they are also secreted from the renal tubule. Filtered from the glomeruli, and while passing, so renal tubular cells also secrete it. So that thing, secretion of additional creatinine into that thing made it some, this procedure it's having some problem, means it will not giving the exact GFR. But it has some very good, it can help us because it is ready. Easily we can determine creatinine, and by that we can assess the clearance. Okay, so how it is done? How can you measure the clearance? Whatever the substance is, the clearance C of X substance, clearance of X substance, it can be GFR. If it is X is inulin. With other substances there is some problem. What problem? The exact GFR we don't get. Either more GFR, more than normal we get, or less value we get. But ideal one is inulin. Okay, how it is calculated? Urine create the concentration of this X in blood, that is in plasma. In plasma, what is the concentration of X? Milligram, that is, what is its unit? Its unit is milligram per dl. And what is the concentration of this in urine? Okay, in urine, what is the concentration of X? And what is the volume? What is the flow of urine? How much urine is formed per minute? That is the flow of urine. So this is the flow of urine. Flow of urine, or V. Flow of urine. How can you? Its unit is ml per minute, and its is milligram per dl. This is simple. Take the urine, measure the concentration. Blood, lower one. Also, it's very easy. Take the blood, separate the plasma, and see the concentration of that substance. Okay. And how we will measure this per minute? Simple. How you can measure? Collect 24 hours urine. Collect 24 hours urine. How much it is? Say for example, 1500 ml. So in 24 hours, flow is how much? 1500. How much it will be in 1 minute? Divide it 1500 divided by 24. Then you will get the value you will get per hour, ml per hour. Then this value, divide it this value with 60. Then you will get it per minute. In this way, you can calculate urine flow. Simple. Only thing you have to collect 24 hours urine. Now, if the substance is inulin, inulin, then concentration of inulin in urine, concentration of inulin in plasma, flow is same. And you put the values, what you will get? You will get the GFR. Normally GFR is 90 to 120 ml of plasma per minute. Understood? This is GFR if we use inulin. But what happens? We want to measure the clearance of, this is measure clearance of inulin, which is regarded as true GFR. Okay. By using same formula, you can use clearance of creatinine, CR. So what is the concentration of creatinine in urine? What is the flow, urine flow? And what is the concentration of creatinine in plasma? So what you will get now, if you put these values in this equation, what is creatinine clearance? One problem is it's not a true, it cannot be considered as a true GFR. However, though it is not considered as true GFR, its value is creatinine level can be changed. If you eat more flesh, more meat, your creatinine level production will be more. Okay, if you do severe exercise, it will be more. So there are conditions in which creatinine level, in physiologically also, normal condition creatinine level fluctuates. That's why we cannot depend so much on creatinine for GFR. Or we will rely particularly more precisely on inulin. Okay. So if you want to calculate the clearance of PAH, para-amino hippuric acid, pH. You can also, this clearance value of pH. You want to calculate clearance of pH. So what you have to do? You have to measure the concentration of it in urine as well as in plasma. So it is PAH Here it is pH. Here it is pH. Now the value you get, it is the value of pH clearance. I will come. Now what? Why should I? Is it of no value? Then why should I? If it is of no value, then okay. It is not giving the value of GFR, but it will provide information regarding some other thing. Right? How much plasma is flowing through the kidney per minute? How much blood is flowing through the kidney per minute? That you can determine from PAH. For that purpose, pH is also important. You understood it? What is the importance of pH? We'll see. Okay. So how you can calculate pH clearance? So in this formula, just you put these values, then you will get the value of the pH. Okay. So in this way, you can also calculate, as I said, urea clearance, pH clearance, creatinine clearance, inulin clearance, and another is cystanin C. This cystanin C is a compound, it's a protein produced by all nucleated cells. So these cells produce continuously in a specific rate. So they are continuously, no fluctuation is there. So it is produced and they are neither absorbed nor secreted. It's like inulin. So one problem is cystanin C measurement is very costly. So it is very costly. So however, it is giving you a true value of GFR. So how you can calculate this cystanin C clearance? Just find out the value in plasma and find out their value in urine. Then only you will get urine flow as usual you can determine. So in that way you can measure the cystanin C clearance. See, inulin clearance test, why it is done? As a measure of GFR. Creatinine clearance also as a measure of GFR, but creatinine is not a good marker as inulin. Because what is the cause? Cause is they are secreted from the renal tubule into the filtrate. Some creatinine is directly filtered, some additional creatinine is secreted from the renal tubule into the filtrate. That is the reason. Okay, so that is the disadvantage or because of that it is not giving the accurate value. And urea clearance test, and what is their clearance value? It indicate how efficient the kidney is in excreting waste products. So that value will indicate how efficient the kidney is in removing the waste products. And pH clearance, it is one way it reflects tubular secretory capacity. This is one thing, as well as it can measure renal plasma flow and renal blood flow. In that way, it is also very important. pH, you may get short question on this. Okay, and you have to explain this how pH can be used for renal plasma flow and renal blood flow. Okay, study Shambulingam, the book of Shambulingam. Okay. Another important question, though not relevant for today, that is, what is GFR? What is their normal values? What are the various factors we have already discussed in our earlier classes? These are the various important factors. Okay, try to recall their factors. So GFR is very important, very various factors affect GFR. So all these factors, there are hormones, there are various hormones. These are the hormones, are vasodilator hormones. Thereby, what happens? They increases GFR, and by vasoconstriction they decreases GFR. All these hormones decrease GFR, all these hormones increase GFR. And those points we have discussed earlier. So if I start discussing it, I will not be able to discuss other points. Creatinine, okay. Now, it's very important. Somebody's kidney is affected, creatinine high, urea high, GFR reduced. Then you are interested to know your kidney, the patient's kidney is damaged, how much? Often we hear, the doctor says, nephrologist says, the patient kidney, 50% kidney is lost. Not working. 75% of your kidneys are not working. So how this percentage are calculated? Okay, for that purpose, very important, you have some, often another question is asked, what is this? Whether you see whether there is, this question is there, eGFR. What does this say? E stands for? What is this E? E stands for estimated. Estimated GFR. We'll be estimating, because with this estimated GFR, we'll say how much kidney is working, how much is damaged. Let's see how it is done. You are interested? Okay. How it is done? So, do we have some prediction equation? We have some equation. Okay, there are 3 equations for this to estimate GFR. But with that value, you can say how much your kidney or patient kidney is damaged. This is 1. What is this equation? This equation is called Cockcroft-Gault equation. Simple equation. What is this? 140 minus the age of the patient in years into ideal body weight or the body weight of the patient, divided by serum creatinine. Okay, the patient, it is tested, this is available with you, and age is available with you, body weight is available with you. So creatinine level multiplied by 72 and is divided, and you will get a value, eGFR. You will get a value of GFR, whatever it is. Okay, in that way you can calculate. This is one equation. Another equation is this, modified MDRF. What is this? Modified diet for renal diseases. Modified diet for renal diseases. They have suggested this formula. What is this? This into this to the power 1.54, age in years to the power into, if the patient is female, then you have to multiply the whole thing with 0.742. If the patient is American African, then you have to multiply with another factor, that is 1.210. So in India, there is no question of this, and only if female, you have to multiply this value with this, and if male, no need of multiplying it. So in this way, from this equation, you can get eGFR. Okay, another equation is more tough. What is this? CKD EPI equation 2021. Very latest, and equation is very tough for you to calculate. So what to do? No problem. You are having a machine in your hand, it is ready. So you go for online CKD EPI equation, put the values, you will get instantly you will get the value. So for your patient, instantly you can get the EPR. Okay, so by different means you got the GFR. Now what to do? This estimated GFR varies. Estimated GFR varies with age. Okay, so we have seen what is the GFR. Gradually as age increases, GFR gradually decreases. Okay, then come this. When the estimated GFR is 90 or above, then there is stage 1 kidney disease. See, though it is normal, we are telling the patient is, this normal person is suffering from stage 1 disease. Why? His 10% glomeruli, 10% nephrons are not working. Under normal condition, 10% of nephrons are not working. Only 90% or is working. Okay, so percent of kidney function, 90 to 100% in that case. Okay, in stage 2, 89 to 60%, if the value of the eGFR is this, 89 to 60%, then we call it stage 2, and there is mild loss of kidney function. How much it is? See, 40 to 10 to 40% is damaged. 10 to 40% is damaged. Kidney is damaged. Okay. Then stage 3, mild to moderate kidney function, loss of kidney function. Here 59 to 45% of the kidney is operating, this is not operating. In this stage, 44 to 30% is the GFR. It indicates that this percent of kidney is not working. And here, what happens? See, gradually, no, this function is non-functional. Only this much is functional. And when the GFR, estimated GFR less than 15, this is called stage 3 or kidney failure. And it is called end stage kidney failure. And here, when there is end stage kidney failure, immediately what is suggested? Dialysis is suggested. Or transplantation of kidney is suggested. So when kidney is indicated, transplantation of kidney, when end stage, when we get the glomerular filtration rate less than 15, estimated GFR less than 15, then it is suggested that he should undergo. And before that, during these cases, during this period, the patient has to give dialysis. And here at the last stage, dialysis may not work. Okay, I'll advise you, go through this. This way. Roll up artificial. Just you take this photo, immediately take this, because in your competency it's like that. What is the role of artificial kidneys? Taken? Okay.